The AMC have posted on their website suggested reading material for exam preparation. Aside from their handbook, they've also included textbooks for specific subjects. I've posted the link below, or you can easily Google it and proceed to this tab. Suggested texts for examination preparation. Now we're going to go through the images in this handbook as they are presented in the book, so it corresponds to the question that is presented with. In your exams, when presented with these images, you should not jump into conclusions right away and choose the same answer as described in the handbook. The image may be the same, but the case would be different. This is only meant for familiarization and rapid review. We're going to present it part by part, starting with the ECGs. This shows the normal ECG tracing. Remember that every P is followed by Q or S, then followed by T wave. In the exams, it's important that you can rapidly eyeball the rate, whether it's tachycardic or bradycardic. My strategy is that I look for a P wave that falls close to a vertical axis, then count through the intervals 300, 150, 100, 75, and 60, up to where the next P wave falls. For this, it is approximately 60 beats per minute. Remember that the normal duration of QRS is equivalent to 3 small squares. This ECG shows ventricular tachycardia, characterized by wide QRS that's more than 3 small squares at a rate of more than 100 beats per minute. In this case, it has a ventricular rate of about 150 beats per minute. It can be presented as either monomorphic, all same looking, or polymorphic VTAC that has a beat-to-beat variation. On the other hand, if it's rapid but with normal QRS, that's less than 3 small squares, then that indicates supraventricular tachycardia. This ECG is atrial fibrillation. It presents as an irregularly irregular rhythm with no discernible P waves. If it's rapid, but this time organized, and with P waves that are sawtoothed, then this is atrial flutter. In this ECG, notice that not all P waves are followed by QRS complexes, meaning the impulse from the atria is delayed or not conducted to the ventricles. This is then an ECG showing a complete heart block. This ECG shows diffused peak T waves. That's indicative of hyperkalemia. The initial management is calcium gluconate, which is for cardioprotection against arrhythmia. ECG changes usually depends on the potassium level, but suffice to know for the exams that it can present as tall peak T waves, loss of P waves, widened QRS complex or sinusoidal pattern. Now on to the easier images. This is molluscum contagiosum. Note the umbilications. Obviously, we cannot just conclude upfront that this is the diagnosis. We should always correlate with the case, particularly the demographics of the patient, risk factors, and presentation of symptoms. But in the handbook, it is noted as such. This image is herpes zoster virus at T8 dermatome. It is also known as shingles. This photo is herpes zoster ophthalmicus. That's when the cranial nerve V1 is affected. Note the V1 dermatome involving the tip of the nose. The first photo is ophthalmic herpes zoster. The second one is vesicular herpes simplex. The first photo is Tinea cruris, and the second one is Tinea fasciae, or ringworm infection of the groin and face respectively. These lesions are pruritic and they can become dry and crusted, wherein there's also scaling on the edges of the lesions. The next photo is basal cell carcinoma. This is nodular basal cell carcinoma. The next one is severely destructive basal cell carcinoma of the face and nose. The first is malignant melanoma of the foot, followed by the melanoma of the glans penis, then followed by melanoma or Hutchinson freckle on the face. Melanoma of the toe, melanoma of the eye. This is again malignant melanoma, wherein the most important prognostic indicator for this lesion is the thickness of the lesion. Remember the ABCDE of melanoma? A for asymmetry, B for border irregularity, C for color, D for diameter, E for evolution over time. A lesion which has sudden changes over time favors melanoma. And the type of melanoma which has the highest prevalence is the acral lentiginous melanoma, or the type which is occurring on the hands and feet, primarily in the palms, soles, fingers, toes, and nail units. This makes sense because those are usually the ones exposed to the UV rays. Now, if after the initial excision of the melanoma, you note that the Breslow thickness are the following, you would have to do a wider excision depending on the guideline. If only in situ, or only with dysplasia, do another excision with 5 mm margin. If the melanoma is less than 1 mm, then do a surgical margin of 1 cm. Melanoma of 1 to 4, do a 1 to 2 cm. However, for melanomas that's 2 to 4 mm thick, it may be desirable to take a 2 cm margin where possible. Same with those lesions that are more than 4 mm. For basal cell carcinoma, the margins for low-risk lesions is 2 to 3 mm. For high risk, it is more than 5 mm. Lastly, for squamous cell carcinoma, the margins for low-risk lesions is 4 mm and 6 mm for high-risk lesions. Again, this is for melanoma, and these are the margins for basal cell and squamous cell carcinoma. Next photo is for squamous cell carcinoma. Squamous cell carcinoma of the lips is more common in the lower lip, while basal cell carcinoma is found more commonly in the upper lip. You can also remember this as such. This is lifted from the USMLE Step 1. The next photo is lentigo maligna melanoma or Hutchinson melanotic freckle. This is seborrheic keratosis of the back. The left photo is actinic keratosis. It is cement-like on the skin. The second is pigmented seborrheic keratosis, which is raisin-like. Next is squamous cell carcinoma. This is squamous cell carcinoma in burn cancer, also known as Marjolin ulcer. This is locally advanced squamous cell carcinoma of the hand. This is dermatofibroma of the leg, which is attributed to minor trauma, including insect bites or injections. It's expected that these lesions are composed of proliferating fibroblasts. The clue is the name itself, dermatofibroma. For a moment, I thought that this was a thrombosed hemorrhoid, but this is actually a pigmented basal cell carcinoma. This obviously is an anus. This is anal fistula that has progressed to chronic anal gland sepsis. This is seen especially in immunocompromised patients. Again, you need to correlate it with a given case. This is anal fissure. It is usually presented in a constipated patient with lacerating pain in the anal region. This is pilonidal sinus infection, which is a hair-containing cyst that's usually found in hairy areas of the body. Again, this is pilonidal sinus infection, showing primary and secondary sinuses. This is ingrowing toenails, for the management of which, first you have to lift the nail, remove the nail spicule, pack with cotton wool soaked in alcohol, and if there's the presence of bacterial infection, then you can apply povidone iodine ointment or antibiotics if with cellulitis or suppuration. This is acute gout. This shows the uric acid in synovial fluid manifesting as a negative birefringence under a polarized light, which is the classic feature of the uric acid in acute gout. In contrary, if the case notes a positive birefringence, then that is indicative of pseudogout, which mostly contains calcium pyrophosphate crystals. So my mnemonic would be positive, there's P, and another P for pseudogout, and a lot of P's for calcium pyrophosphate. Next photo is cellulitis. Still cellulitis showing extension of the lesion beyond the original margin. For the treatment, note that the following antibiotics can be used: dicloxacillin or flucloxacillin. However, it can cause side effects such as cholestatic hepatitis, which is commonly observed among female patients aged more than 55 years and in longer courses, that's more than 2 weeks. If there's delayed hypersensitivity to penicillin, then we can use cephalexin as an alternative. However, if there's immediate hypersensitivity, then we can use clindamycin. Note, however, that the natural history of cellulitis shows increasing redness and swelling, even going beyond the margin, within the first 48 hours. You should not automatically change antibiotics or shift to intravenous treatment unless there's deterioration in the patient's overall condition. Next is fixed drug eruption. Do not confuse this with the next image, which is necrotizing anaerobic fasciitis of the back, which shows evidence of gangrene, necrotic change, or gas formation. Next is pyoderma gangrenosum, which is a large painful sore. This is lupus erythematosus with facial and hand rash. This is Gottron papules, signifying dermatomyositis. This is characterized by scaly and erythematous lesion, especially on the extensor surfaces. This is sclerodactyly. This is scleroderma of the face. Remember the different autoantibodies for the different types of scleroderma. The way I remember it is that for diffuse scleroderma, it's widespread, for which the antibody is anti-SCL, 70. And, well, 70 is a lot, or widespread, hence diffuse scleroderma. As compared for localized scleroderma, or CREST syndrome, which starts with C, it tests positive for anti-centromere. Also, there's letter C. So diffuse, 70, CREST, centromere. CREST stands for calcinosis cutis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Next photo is local drug reaction. This is also allergic rash from amoxicillin. This is median nerve palsy. This photo rather needs correlation, of course. Note that median nerve innervates the first to 4.5 digits of the hand, and it can either present as inability in making a fist or inability in extending the fingers, depending whether the nerve is affected on the proximal or distal part. Differentiated from ulnar nerve palsy, note that it innervates the lateral 4th to 5th digits of the hand, and it may present as either difficulty in making a fist or extending the fingers, still depending on the part that is affected. This photo is Dupuytren's disease, which is the thickening and fibrosis of the palmar fascia. The succeeding photos will show the severity of the disease. This is Dupuytren palmar nodule and early contracture. The next one is the advanced contracture. Remember the risk factors for Dupuytren disease. Primarily, it is idiopathic. However, you should also note the history of smoking, alcoholism, liver cirrhosis, COPD, epilepsy, heavy manual labor, for which the management is corticosteroids straight into the cord. This is congenital contracture of the little fingers. This is Hansen disease or leprosy, affecting the ulnar nerve. This is diabetic chiroarthropathy or diabetic hand syndrome, also known as stiff hands syndrome, which tests positive for Payard test. Note the gap in between the digits. This is psoriasis. This is exanthematous dermatitis or acrodermatitis enteropathica, which is associated with zinc deficiency, hence the management is zinc IV. This is eczema of the elbow. This is flexural atopic dermatitis, multinodular goiters, thyroglossal duct cyst, And the next photo shows movement of the lesion with deglutition or with the tongue. Now, the AMC may show any of these photos, but again, you'd have to understand the context for you to choose the right answer, and it may not be the same as what's shown. The first one is parotid carcinoma, pleomorphic adenoma, chronic parotitis. Same with these, pleomorphic adenoma, a CT showing pleomorphic adenoma, as you can see with the indicated dimensions of the lesion, and adenolymphoma of the parotid. There's really no use in memorizing them, just be familiarized. That's it. Next is supraclavicular lymphadenopathy, which is associated with metastasis from lung cancer, particularly Pancoast tumor, a tumor in the apical part of the lung. This X-ray shows that Pancoast tumor.